Hello, my name is Amit Pawa, and thank you for joining me for this short video, which has come from a pro-con debate I did at the Association of Anaesthetists Winter Scientific Meeting in January 2024. And there, spurred on by the NAP7 project, we took part in a pro-con debate looking at whether or not we should get rid of anaesthetic rooms. I took on a very talented speaker called Jan Hansel, who was defending the motion, talking about getting rid of anaesthetic rooms, and my role in this debate was to argue against getting rid of anaesthetic rooms. We wrote an editorial based upon this, which was published in Anaesthesia, and I was assisted by two very talented colleagues of mine, Charlotte Cobain and Sam Wong. So if you go on to the Anaesthesia website, you will find that editorial there. Now, in case you're thinking that you've tuned into the wrong video, why on earth have you got a video of a big yellow taxi? You haven't gone mad, and I haven't gone mad. This is very relevant to the talk I'm about to deliver. What am I talking about? I am, of course, referring to this lady, and for those of you who don't realise who this is Joni Mitchell. Back in 1970, Joni Mitchell wrote a song entitled The Big Yellow Taxi. And I'm going to show you what one of the hooks of that song was. It was, "You don't know what you've got till it's gone." And I think that's really relevant when it comes to talking about anaesthetic rooms, because the truth is, once we lose our anaesthetic rooms, it'll be very difficult for us to get them back, and then we'll suddenly realise what set us apart from the rest of the world and how beneficial they were to us. So let's get on to what I'm about to talk about today. The motion was anaesthetic rooms are no longer needed. And I was opposing the motion. So if we get into the main parts of the talk, I do have to talk about my disclosures first. You will, as I hope you know that I take part in a podcast called Block It Like It's Hot. I have a YouTube channel which hopefully you're watching this on, and I have some industry sponsorship, none of which will impact on my ability to deliver this talk. There is one thing that is relevant, however. I regularly induce anaesthesia inside operating theatres, and you know what the truth is? I don't like it. Now, for those of you who haven't got time to sit and listen to the whole 20 minutes of this talk, I'm going to give you the too long didn't read summary. I believe that anaesthetic rooms should stay, but if you're going to use them, before you transfer from the anaesthetic room to the operating room or operating theatre, check and treat blood pressure, heart rate and saturations, and treat any abnormalities of those before transfer. We should all be using continuous monitoring as per the Association of Anaesthetists guidelines, and if you do have those high-risk patients where getting on with the surgery is really paramount, you can't waste time, anaesthetise those patients directly in the operating theatre. The rest of this talk will cover some themes, and I'm going to try and give you the headlines of those themes. Firstly, privacy and how important privacy is in this debate. Then preparation and how anaesthetic rooms assist us in this manner. Then we're going to be talking about the impact of anaesthetic rooms on efficiency. The impact of anaesthetic rooms on training. And finally, the impact of anaesthetic rooms on patient safety. We can't really start this debate without looking at NAP7, the national audit project that took place in the United Kingdom that triggered this whole debate. And let's look at the focus on anaesthetic rooms to start off with. This QR code will take you to all the references where this information comes from. So what do we find out about anaesthetic rooms? They are present in 96% of departments in the UK. So 96% of departments in the UK have anaesthetic rooms. Now in 2019, 80% of adult patients had their anaesthesia induced within the anaesthetic room. compared to historical data from 2002 where 90% of adults were anaesthetised in anaesthetic rooms. Bring on the pandemic, and of course those numbers fell down to 18% of adults were induced in the anaesthetic room. But lo and behold, after the pandemic, we went back up to 79% of adults having their anaesthesia induced in the anaesthetic room. The question is, why did we return to the anaesthetic rooms? Did we just do it because of force of habit, or was there another reason that we were desperate to get back to our anaesthetic rooms? And that's something I want you to think about. Let's start off by looking at some of the data that came out of NAP7. So the first thing we can look at is the whole purpose of NAP7 was to look at peri-operative cardiac arrest, and they worked out there was an incidence of about 3 out of 10,000 from the 881 peri-operative cardiac arrests that they had. Of this number, 627 of those arrests occurred within the operating suite, and in 393 of those, an anaesthetic room was used. Of those 393, 136 of those arrests occurred before surgery. And if you look at those 136 arrests that occurred before surgery, 63 arrested within the anaesthetic room itself, 10 on transfer to the operating room, and 56 of those occurred before the knife hit the skin, so before surgery. So many of you will be wondering, am I trying to say that the anaesthetic room is the problem here? The answer is I'm not trying to say that. And what we can actually have a look at is the timing of the cardiac arrest within those two groups, those that were anaesthetised in the anaesthetic room and those that were anaesthetised directly in the operating room. If we look at that data here, you'll see when you look at the first column, which is when an anaesthetic room was used, and the second column when an anaesthetic room was not used, the timing of arrest was pretty similar between the two groups. So actually there was no difference based upon location. What we can see, however, is that 7% of patients had their cardiac arrest on transfer to the operating theatre. Now that's clearly not great, but most importantly, 33% of all transfers had no monitoring attached to them. Now this is something that really does need to improve. The next thing we can look at is the top 4 causes of peri-operative cardiac arrest, and they were hypotension, bradyarrhythmia, hypoxemia, and anaphylaxis. Now I'm going to go out on a limb here and say that it's possible for you to diagnose and treat each of those causes of cardiac arrest before or immediately after transfer to the operating theatre. I can say this with a certain degree of confidence because I've had 4 cases of anaphylaxis, 3 of which occurred in 2023, and to these different agents. You can see 2 to cefuroxime, 1 to teicoplanin, 1 to patent blue. In each of these, with the exception of the patent blue case, I was either able to diagnose in the anaesthetic room itself or immediately after transfer to the operating theatre. And the reason I was able to do that is because I had continuous monitoring in place in all of those circumstances. So either the patient was monitored completely during the transfer, or as soon as we arrived into theatre, I was able to dock the module and get the number straight away without a delay. And that, I think, was paramount in allowing me to diagnose and treat those cases of anaphylaxis. Let's start looking into a bit more detail now. We're going to start looking at those themes I referred to earlier on. The first theme is the importance of privacy for anaesthetists and how anaesthetic rooms can help us. Anaesthetic rooms provide privacy for us as anaesthetists, and certainly they allow that process of reducing performance anxiety. If we wanted to be front and center, we would have been surgeons, but actually we like to operate in safe, controlled, calm manners and have the ability to react to changes and alterations when necessary. So anaesthetic rooms give us that place for privacy. There are fewer distractions, and actually in order to achieve the task that we need to involved in that preoperative phase of anaesthesia, there are far better ergonomics within the anaesthetic room for us to do that. You know what it's like when you try to do something in theatre and you're not used to doing it, things change. For example, if you were to look at the last time I had to cannulate prior to inducing anaesthesia directly in the operating theatre, the patient looked a little bit like this. Of course, that's slightly tongue-in-cheek, but there is no doubt that when I do that first phase of anaesthesia in the operating theatre, it feels different. It doesn't feel so nice for me as an anaesthetist. What about privacy for our patients? You can imagine what it's like for a patient walking straight into the operating theatre or operating room about to have the anaesthesia. It can be daunting, it can be scary, it can look something like this. We don't want this to be the case for our patients. I've referred to the fact that operating rooms are scary and unfamiliar areas for our patients. There are often loud noises and distractions. You can hear the scrub nurses counting their instruments. There are other people talking, getting on with other tasks unrelated to the induction of anaesthesia. There are many staff present in the operating theatre at the time of induction. Often, some of them don't actually need to be there. What we have when we have our anaesthetic rooms is a safe haven, free from distraction, with the minimum personnel required. And imagine if you were a patient and you came in to the operating theatre and you were greeted by the sight of this. Nobody wants to see all of the cutlery that's going to be used prior to their surgery glistening or glinting under the operating theatre lights. So anaesthetic rooms allow us to shield patients from those sights. Now let's talk about preparation and how anaesthetic rooms help us. They allow us to prepare our medications without any distractions, and we know that drug preparation is really key, is a really key phase of anaesthesia, and we don't want to be distracted when we're doing that. Being able to retreat into anaesthetic rooms and do that without distraction is a real advantage. The other thing we can do is set up in advance for the next case. So we may have a patient in the operating theatre already, in the operating room, having surgery, and if we want to start thinking about the next case that's on the operating list, we can retreat into the anaesthetic room while somebody else is monitoring the patient and prepare drugs for the next case without the fear of cross-contamination with the current patient in theatre. Anaesthetic rooms have the ideal ergonomics for drug preparation and equipment preparation because we have lots and lots of equipment storage. We can also use our anaesthetic rooms to have a quick break, to have a coffee, or even to have a lunch if we're on a long list without anyone to relieve us. It allows us to discuss upcoming patients on the operating list or other patients without distracting the surgeon from their task at hand. The other thing we can use anaesthetic rooms for is to pop and have a very quick Zoom or virtual meeting with other teams or members of staff. And here is Professor Elbog Dadley, who was chairing our Procon session, having a Zoom meeting with Jan Hansel, against whom I was debating. This is slightly tongue-in-cheek, but it allows us that ability to have discussions in the anaesthetic room without distracting the surgeon. I talked about the fact that anaesthetic rooms are optimized, and actually here is a paper where they looked at the design of anaesthetic rooms and came up with the optimal design of an anaesthetic room to allow both the anaesthetic assistant and the anaesthetist to get on with their tasks. And actually this represents the type of setup that I find in many of the anaesthetic rooms that I work in. If you try and replicate this in an operating theatre, you're limited by space and you're also limited by storage, so the ergonomics of this is less ideal, and it's very difficult to replicate this anaesthetic room setup in the operating theatre. Now, you may or may not be aware of this publication called the Hospital Building Notes, and this is referred to by all architects whenever they're building a new hospital. And essentially, they make a number of references to anaesthetic rooms within this document, but one of the things they say is excluding anaesthetic rooms has space and design implications for the operating theatre area. More significantly, and I didn't know about this, the omission of an anaesthetic room will compromise the ability of theatre suite ventilation system to maintain pressure. So this is a really important reason to keep anaesthetic rooms as well. Now let's look at efficiency. Now clearly I talked about how we can potentially use the anaesthetic room in clever ways. So we can actually get the next patient into the anaesthetic room early in advance whilst there's a patient already on the operating table. What that allows us to do is to attach them to the monitoring, to cannulate them, and maybe even do a nerve block that would be used as their mode of anaesthesia in advance. This kind of workflow is called parallel processing. So what we're doing is using our anaesthetic room as a block room. Not all hospitals have the staff or real estate to have a separate area of the operating suite that they can call a nerve block room. So we're just using the space we have already, so using our anaesthetic room as a block room. The advantage of that, of course, is that once you place the nerve block, you can make sure that that nerve block is cooked before the patient is transferred into the operating theatre. If you do your nerve block directly in the operating theatre, there's a temptation for the surgeons to start before the nerve block is ready. Here you can keep the patient in a safe area and only transfer them to theatre when the nerve block is ready. We also minimise theatre downtime by using this parallel processing idea and getting the patient into the anaesthetic room in advance, and that may even result in us allowing having the ability to do an extra case on the list. The other thing that using the anaesthetic room for in terms of increasing efficiency is maybe to care for another patient. So it may be that whilst you've got a long case on the operating theatre, there's another patient that needs a central line place for access, or needs a nerve block for analgesia, such as a patient with hip fractures or rib fractures. You can actually use that anaesthetic room as a separate procedure room whilst you have a patient on the table. So that's another use showing how we can increase efficiency. Many people will say, what's the big deal? How long does it actually take to turn around a theatre? Well, with one of my most efficient operating theatre teams, I said to them, just as we're about to leave theatre with patient number 1, I said, right, I want you to imagine that we can't anaesthetise patient number 2 until you've cleaned the operating theatre and turned it around, and you'd be ready for me to walk that patient directly into operating theatre to have their anaesthetic. So I'm going to time you. Let's see how long it takes for you to get this theatre ready. And I timed them. It was 17 and 3/4 minutes, so nearly 18 minutes from when the first case left the operating theatre until they would have let me start anaesthetising patient number 2. Clearly, if I didn't have to wait for the operating room to be ready, that turnaround time would have been much quicker. In the UK, we have big waiting lists of operations that still need to be done, and anaesthetic rooms, as I said, can help us with efficiency. And one such innovation is the use of high-intensity theatre lists, which were pioneered at Guy's and St Thomas's. And what these end up doing is getting a large number of patients, a big team, and they work their way through a large number of the waiting list of cases in one day. Now, these high-intensity theatre lists use anaesthetic rooms to help facilitate that process. So when a patient is leaving the operating theatre, the next patient is already being anaesthetised and induced in the anaesthetic room. And clearly, if you use this type of process, you can increase theatre cases performed by up to 150%. The next theme I wanted to talk about was training. I already mentioned that performance anxiety, but it can also be difficult to train our learners in the operating theatre with people watching. You know what it's like when you're trying to put in a drip, you're trying to do a nerve block, you're trying to look after the airway while people are watching. Sometimes it can be distracting, and it's not a great environment for teaching the anaesthetists of the future. The other thing we know for definite is that procedural success is greater within the anaesthetic rooms when you haven't got those distractions there. The quality of the teaching improves and the trainees feel less embarrassed or less under pressure. It's a supportive environment for teaching, away from prying ears and eyes, and you can focus on getting those trainees to achieve the best results for the best outcomes. The other thing that anaesthetic rooms allow us to do is to step our trainees up that kind of confidence levels by saying, I'm going to retreat into the anaesthetic room, you take care of this case in the operating theatre, but you're close at hand should the need be required. The last theme I wanted to talk about is safety and patient safety. Anaesthetic room is only there for the patient. It's dedicated to the patient. That means that we are distraction free. We've got all of our equipment to hand. We can pay full attention to the monitors as they might be beeping or indicating something abnormal. We're not distracted by what's happening in the operating theatre. Most importantly, there are no interruptions at critical phases, such as the immediate induction of anaesthesia, securing the airway, placing a spinal, sticking a needle near to the pleura if you're doing a paravertebral block. We have no chance of anyone distracting us because we're locked away. We're not locked away, but we're separate in that room. The other thing you can do is if the patient has a language barrier or anxiety issues or has another reason why they require a chaperone to be present, you can have that chaperone in the anaesthetic room without thinking about having to get them into theatre and the logistics of that. So let's summarise what I've said so far. Anaesthetic rooms provide privacy. They provide a dedicated preparation space. They enable efficiency. They facilitate training. And they are safe and distraction-free. So in theory, I could drop the mic there and say I've discussed everything I need to, but we're going to look at some other circumstances. So let's look at some of these special circumstances. And let's imagine kids and anaesthetic rooms. It's often really important to have parents present during induction of anaesthesia for paediatrics, and if you have an anaesthetic room, you don't have to worry about getting the parents changed into scrubs, the time delay that may cause, the impact on the resources that are available for the rest of the staff, and also laundering costs. It also means that if you limit the induction of anaesthesia with a child to the anaesthetic room, you're minimising the exposure of staff to repetitive anaesthetic vapours during a volatile induction. It also means if you decided to use bubbles as that distraction technique, those soap bubbles to help a child with induction of anaesthesia, you're not worried about those bubbles dropping onto sets and contaminating the beautiful sets that the nursing staff have got ready for the case. Now, we talked about kids, and this is a kid pointing to his knee, so I am of course referring to kidneys. What do I mean by that? I'm talking about kidney transplant. Now, at my institution, for renal transplant cases, the organ to be transplanted is often benched or prepared directly in sterile conditions in the operating theatre. And whilst that process is happening, we have got the recipient getting prepped in the anaesthetic room. And that means that we're minimising ischemic time. And there wouldn't be a situation where we could have the kidney being prepared in theatre whilst the patient is also being prepared in the same operating theatre. What about other special circumstances? So here are two potential ones, major blood loss or difficult airway. There may be other instances where you have other emergency or high-risk patients with a large BMI or other issues where you just need to get on with things straight away. In those cases, of course, anaesthetise them in the operating theatre. At no point are we talking about not doing that. But for the vast majority of cases, you don't need to do that. Now, there may be some circumstances where there are some rebuttals, and I want to take some of those on. The first one relates to the National Audit Project number 5, which is looking at accidental awareness under general anaesthesia, and specifically this particular point is referring to awareness on transfer from the anaesthetic room to the operating theatre. Now, 12 out of 141 cases of accidental awareness under general anaesthesia occurred during this phase. But back then, the majority of those patients were receiving volatile anaesthesia. Now, Many of our patients are receiving total intravenous anaesthesia, and we have continuous monitoring in place. So I believe the incidence of awareness on that particular phase, the transfer from the anaesthetic room to the operating theatre, should drop further. The other thing people look at specifically is talking about the anxiety levels between the anaesthetic room and the operating theatre, and I strongly believe that patients are less anxious in the anaesthetic room as opposed to being induced in the operating theatre or operating room. But there was one paper that has been often quoted, and that paper showed no difference between patients that were anaesthetised in the anaesthetic room versus those that were anaesthetised in the operating room. But this paper was back from 1989, and all of the patients were seen one day preoperatively by the anaesthetist. Now, I think that in itself is anxiolytic, but more importantly, every single patient that was anaesthetised had somewhere between 10 to 30 milligrams of temazepam, a benzodiazepine, pre-operatively as a pre-med, and I think that would reduce your anxiety levels no matter where you were anaesthetised. This does not reflect current day practice. The other rebuttal people come up with is in the rest of the world, people manage without anaesthetic rooms, and they quote the United States of America as an example where that whole service manages without anaesthetic rooms. But in the United States, they have holding bays where patients get administered or brought into the operating suite earlier on, and they get cannulated there. And they also have block rooms or block bays. So they're using that physical area like an anaesthetic room. They're connecting the patients up to monitoring. They're sitting cannulas in. They're doing nerve blocks. That's what we would do in our anaesthetic rooms. They also have separate prep rooms. So their surgical equipments are being prepared in a separate space to the operating room. So effectively, if you take a patient into a large operating theatre when no other activity is happening at that point because the preparation is happening outside, that's like bringing them into a big anaesthetic room. The other thing that may happen is surgeons may be running two operating theatres or two operating rooms simultaneously to deal with efficiency, and also anaesthetists may be running multiple operating rooms with the assistance of other members of the anaesthesia care team, such as certified registered nurse anaesthetists. So for those reasons, I think despite the fact they're anaesthetising the operating theatre, they are doing other things to increase efficiency that doesn't reflect what happens in the UK. So I thought, wouldn't it be great if we got an American anaesthetist to come and look at what we do in the UK and let us know what they think of our setup? Well, it just so happens that we were visited by an anaesthesiologist from the United States, a doctor called Dr. Sean McManus, and I want to share with you what he thought.
For someone practicing in the United States, anesthetic rooms are a welcome change of pace from the typical operating theater workflow, and they have a way of enhancing the patient experience on day of surgery. Three main benefits come to mind when I think about my experience with anesthetic rooms. One being patient comfortability. Patients are far more relaxed when they come back to an anesthetic room to an anesthetist whom they've already had a conversation with, instead of entering a large, cold operating theater with surgical instruments on display and a group of unfamiliar faces. Second benefit being compartmentalization of roles. Anesthetic rooms are used for principally that, the induction of anesthesia. Those present in the anesthetic room are there to help achieve the task of a safe induction of anesthesia. This is different from an induction in the operating theater where there are many side conversations going on. You have our surgical colleagues going over preoperative imaging in the corner. You have our nursing colleagues going over preoperative instrument counts and many different tasks not related to the goal of induction of anesthesia. Anesthetic rooms achieve this goal by providing a safe environment for the induction of anesthesia. Third benefit being the efficient use of operating theater resources. The anesthetic room provides a space for preparation for the case to follow and noticeably enhances and speeds up the theater turnover times. Personnel and theater resources are used most optimally when you have these anesthetic rooms to help with this task. For those three reasons, I am all in on the use of anesthetic rooms.
Thank you, Sean, for sharing your thoughts with us. So, how do we conclude? Well, the way I'd like to conclude is by looking at this chapter. This chapter was called Anaesthetic Rooms, Mind the Gap Again, by these two authors, and I want to summarise what their conclusions were, but with my interpretation. They said anaesthetic rooms should stay for now. That's my interpretation, because there isn't evidence to get rid of them. They also say we should check and treat any abnormalities of blood pressure, heart rate, and saturations before transfer to the operating room. They state that we should use continuous monitoring as per the Association of Anaesthetists guidelines, and that we should anaesthetise high-risk patients in the operating theatre. So going back to our motion, anaesthetic rooms are no longer needed. I think that you should vote against the motion, because if you don't, you won't know what you've got till it's gone. Thank you very much for taking the time to listen to my presentation, and I hope you found this interesting and thought-provoking. You can follow me at the rest of those social media profiles. Many thanks.